Just I didn't introduce, I thought I'm putting this for a specific reason, that I want to introduce you that, of course, you all know, maybe so many of you are members of OSOG, which is Omani Society of Obstetrics and Gynecology. There are subgroups in the society, which are fetal medicine, they are fetal-maternal group, and there are the fertility, Omani Fertility Gynae and Endoscopy group, which is part of the Omani Society group. So we are, me and myself and Dr. Naama are part of that group, who are having we are the one who are looking after the fertility, the endoscopy part of lectures and symposiums done on the Omani Society of Obstetrics and Gynecology. Again, we are, inshallah, I'm going to take you through the history of the IVF, what all the IVF technology, preparation, evaluation, success rate and complications, pregnancy follow-up after IVF, how to follow up them and how to consider them, and they are a high risk of pregnancy, IVF application beyond infertility, and then finally I will summarize my presentation. Again, I already show you this, and you know that the infertility is a global public health issue, and we have to take care of these fertility and infertility patients. Yes, IVF is a solution for some. It's one of the several techniques available to help people with fertility problems to have a baby. 3 to 5% of infertile couples will go for IVF. Worldwide guidelines recommended IVF should be offered to women under the age of 43 who have been trying to get pregnant through regular unprotected sex for 2 years, or who have had 12 cycle assisted fertility treatment with at least 6 cycles of an IUI. So if this is the maximum, okay? Of course, you don't want to see a patient at the age of 43 sending her for IVF. So this is the maximum. Please send them earlier than they become to the maximum part. However, of course, the final decision will be on the patient herself and the treating doctor. The history of IVF, as you all know, it started in 1978, as we all know, with the born of the Louis Brown. That is in 1978. After that, the progress, so many, lines in the IVF history started after Louis Brown. Although the first baby born in 1978, but the IVF started experimental, in fact, in the 19th century. They started in 1878 with the use of rabbit to see how it works. Then in 1970s, where the pioneers started working on the IVF, the experimentation, and then the IVF baby born in 1978. In US, in fact, it's later than UK. Of course, that was in UK. They started in 1981. And in fact, after that, the progress in US is far more advanced than in UK. They start to progress more than UK. For now, we are becoming more familiar. If you come like something like 20 years back in Oman, we were not familiar, maybe. It was a little bit hesitant starting the IVF. Now it's very normal concept. People are going for IVF normally. There is nothing to worry about, okay? But we need regulations, and that started in UK in 1982 when they have recommended regulatory guidelines by the fertilization and embryology. So that is almost after 5 years from the born of Louis Brown. That the IVF opened the gateway to deeper understanding of human reproduction. Now they start to have more scientific researches to use how to advance further. We start using the human embryo stem cells, the gene edition, mitochondrial donation after that. Then, after that, people start talking ethically now. Yes, we have the IVF, we have all these techniques, but we have to think ethically now. We have fear of designer babies. We need the most intelligent. Let us look for the gene of the intelligence. Let us look for the gene which make a good body muscle. Not for the treatment of the patient who are having abnormalities or BGD or abnormal genes. No, we are looking for a designer, a super human who are having all the good things. This is what we said. Then people start getting fear. No, we are going beyond now. As if we start getting the rule, we are playing the role of how to modify the things according to what patient, we're designing the things now. So yes, now international litigation started. So people before that, before in the 90s, in fact, there are so many, if you go into the net, and there are lots of labs here and there in the world where they don't have some sort of litigation or regulations, are doing so many experiments in designing humans. But after that, when we open our eyes that they need to have sort of regulations in order to control this. Egg donation, surrogacy came, freezing of embryos, mitochondrial transfer, genome edition, a child with 3 parents. Then we start to know. Now, a baby coming from 3 parents, father, 2 fathers, 1 mother, it's depend on the what type of, from where they get. So this is the things which really starts now thinking more. People start thinking beyond only getting a child. We have to think more now about ethics. Then we are now morally thinking, when the baby is starting having the life, is it the sperm is alive? They start thinking in that way. It's the egg is alive, it's the oocyte is alive. Shall we call the life started when the sperm and egg fertilize during the fertilization? What is the age I should mention that this is the life? Because if you say that this is now the life, the point of life, then you have that thing is have to have some sort of rights. Human rights started. Then people start thinking of human rights, because we had a conference in 2020 February in university regarding the human rights, and at that time there are some countries in Europe, they did not legalize using, in fact, BGS. You know that some countries like Sweden, they don't legalize BGS. They don't legalize doing chromosomal, looking for Down syndrome, for example, because they think Down syndrome is a person who has a right to be alive. Why we should not give him the chance to live? Although you can debate that, you can say, yeah, look, they have a lot of problems, health issues, social issues, and all that, but they are human. Why? Then somebody else put in mind, in fact, that they said, even BGD. Why we should say that this person with a sickle cell anemia, I should not give him the chance to live? Who says? He can be treated, he can be given stem cell, he can be, why I should? In fact, one of the patients, they wrote the story, and then she is a sickle cell disease patient, and she is a lecturer in the university, and she says, Alhamdulillah, I was born before the BGD. Otherwise, my parents will choose not to bring me up, and I will not be around now. So in all these things started to come, and people start to think in this very, very deep in this subject. It's not only an IVF, we have to think deeper. As you all know, there are many indications to have an IVF, like tubal disease, endometriosis, ovulatory dysfunction, age-related infertility, male factor, and BGD and BGS. The evaluation before IVF is very important. Female factor, age, previous medication, previous pregnancy history, her BMI, lifestyle factors, advanced maternal age. Even maternal age is very important, because now the literature says that advance in the father age can affect the IVF outcome. If it's not the success rate, at least the outcome of some of the diseases like autism. So if you want to prepare your patient for an IVF, general evaluation for the couple by doing serology is very important, because you know that some of these cycles will end up having freezing, and you don't want to freeze the sperms and the oocyte or an embryos of an HIV patient with normal patient. The risk of transition is very, very low, but it is there. So that's why serology is very important before sending patient for an IVF. Female general investigation is also important, like especially the blood sugar, especially in a community like Oman, where have a high incidence of diabetes of around 25% of our population. Thyroid stimulating hormone, prolactin, ovarian reserve is very important. Cavity assessment by doing an ultrasound, if necessarily a hysteroscopy. Cervical smear is very important because you don't want to treat a patient who are having an CIN, for example. You have to treat her CIN before taking her for an IVF. And semen analysis. And of course, if there is any sort of genetic problems, you have to counsel for that. So the IVF medication usually started with gonadotropin, GnRH antagonist, GnRH agonist, with all its implications, as we talked before about that. Human chorionic gonadotropins and progesterone for the luteal phase support. Usually, we decide on the, after we see the patient, review her investigation, her previous history, what all medication she used before, what type of stimulation she did in her previous IVF cycle, what is the outcome of the previous IVF cycles, how many oocytes we got from the previous IVF cycles, how many fertilization rate, what is the outcome of the embryos, is that protocol, what type of protocols they used in the previous IVF cycles. Maybe you need to change that protocol, because some of the patients, we found that even a change of medication from one company to another company may give you a different outcome. So that's why you have to know each and every details, even the type of medication they use up to that stage. Sometimes we do. And then, of course, as we said before, individualization is very important. And that's what you have to choose the proper protocol for each patient, not all the same. So the protocol, as Dr. Naama discussed, and I discussed also before, there are different types of protocols, and we choose it according to the patient need and requirement. And there are antagonist protocol, either it's fixed or flexible. And it's fixed and flexible, you know, it depends when you introduce the GnRH. Are you introduce it directly after 5 or 6 days from the starting of the stimulation, or only after the oocyte become larger than 14 millimeter. Then you have the long agonist protocol, and each one of them having its own indications. And then you have the microdose, and they're choosing some sort of minimal stimulation, especially for those patients who are having, very high chance of having ovarian hyperstimulation, very high anti-Mullerian hormones, very high intrafollicular count. You try to give a very minimal gonadotropins. And sometimes you need to prepare your patient for IVF. For example, if you examine her today and you find that there is an ovarian cyst, this can have a bad implication on the outcome of the IVF. So either you postpone the start of the stimulation, or you go and aspirate that cyst, or you give her some sort of medication like for example, triptorelin or birth control pills. And even sometimes if they have an endometriosis, as we said before, maybe you need to give them some sort of suppression prior to the IVF. Then we come to the OPU. Usually when the patient are ready, we give them the HCG, the Pregnil, the Ovadril, as I mentioned before, and then between almost 36 hours from that time, we will do the OPU, which is usually done under conscious sedation, minimal sedation we give, and we sort of, and then we do it transvaginally. Rarely we do it abdominally, and we retrieve all the oocytes from the follicles, and we send them to the lab in order to be fertilized on almost the same day to have the to know how many of them. Of course, not immediately when we give it to the lab, they have to differentiate how many of them they are M2, they are good to be fertilized, and then after that, the fertilization done. So now, how we choose between IVF or ICSI? Is an IVF, there is an IVF and there is an ICSI. So how I do differentiate that this patient needs an IVF or she should go for ICSI? And they are totally different, and even cost is different. So usually the IVF patient, most of the patients should go for IVF. In fact, 90%, if I'm not exaggerating, but 90% of the patients should go for IVF. There are minority who may fail the IVF, which is around 10 to 15% when the patient are having total fertilization rate. What is the IVF mean? That we bring around 20,000 sperms, put them in the tube with one oocyte, hoping that the good sperm will go and fertilize naturally. So the good sperm will go and fertilize that oocyte. So this is the good. Where the ICSI, which is much expensive, is performed only in a mature egg, which can rule out and some of the oocytes which you retrieve, and which is around 20%. And sometimes with the ICSI, because it's a manipulation, it's under the microscope, and you manipulate that egg. And sometimes when the embryologist put this sperm inside, part of the sperm inside, they may damage that oocyte. So that's why you have to put this in mind when we choose between IVF and ICSI. That's why we say most of the time IVF is lab, because you need really a good hand to manipulate these microscopic tissue, human tissue. So the patient who may benefit from which approach, if we talk about in general, all male factor, it's very little. All male factor, if you think about male factor, it's very little who will benefit only from ICSI. Most of them still, with that male factor, they will benefit mainly from IVF. Severe male factor, 36% of these IVF cycles lead to, even if you do IVF, they will benefit from with severe male factor. ICSI is not that much. Poor morphology, you need only 55% of the sperms, the good sperms. So that better run studies indicate that ICSI does not improve the live birth if you choose, and recent meta-analysis even proven that IVF is better for them than ICSI. Moderate male factor, same. Non-male factor, most of the statistics, most of the analysis says that IVF is better than ICSI for the non-male factors. With unexplained infertility, no significant difference between the patient who used IVF or ICSI. So better to go for IVF. That will decrease even the financial burden on the patient. With the poor responders, in fact, with the poor responders, the ICSI had lower success rate. Why is that? Because anyway, they have, few oocytes. And if you put those few oocytes under not a good hand of an embryologist, they may damage them further. And you have maybe a poor outcome. So that's why, even with those patients, in fact, IVF is better. Advanced maternal age, they are little bit, unless you are going for BGS, otherwise not much difference. With previous total fertilization, yani with IVF, they have fertilization failure. That means the oocyte did not fertilize. Then maybe with this patient only who will get better to go for ICSI. Tubal factor does not improve, so better to go for IVF. Cryopreserved, in fact, IVF with the cryopreserved eggs, IVF is better. Cryopreserved sperms, anyway, we have low number, so that's why they are very precious sperms, and you have to go for ICSI. So there are many literatures who discuss this. Is IVF better than ICSI? ICSI is better than IVF, and what should be? The high quality studies came in the last 3 years, which says that IVF is better than ICSI in many of the patients. Summary for this study, which was published in 2021, that IVF should be the choice of assisted reproductive techniques in non-male factor infertility cases. Is it for fertility preservation? I say, again, IVF is better unless they have poor sperm analysis. That's why finally in the issue, in the last issue which was conducted in SRM, they combined usually the both conferences. They have a combined issue and SRM in 2019. They said we have to be wise and we have to use our common sense and not to take all the patients to go for ICSI. We better see which one is, we have to choose those patients who go for ICSI. So this is just a journal where which one is who to go, and it summarizes all the literatures. This is the recent study which came just in November, says the meta-analysis now says that ICSI versus IVF in a couple without male factor, IVF is better. So now we have proven that IVF better in most of the cases, and that's why I say IVF is better than ICSI in almost more than 90% of the cases going for IVF in general, ART in general. For patients who are infertility more than 5 years, have low fertilization rate, in this study, which was conducted in just November 2022, they said infertility for those patients who are more than 5 years has low fertilization rate, ICSI did not improve the fertilization rate in non-male factor causes. So this is a meta-analysis now, which is really very important to be taken in consideration. And then after we choose IVF or ICSI, now we will go to embryo transfer. The number of embryos to be transferred have to be taken into. There are countries who in fact put it as a crime. They can sue that center if they put more than one embryo. Like in Scandinavian countries, they allow you only to put one embryo for those patients who are below the age of 35. But for most of the countries, if they have a patient who are below the age of 35, it's allowed 1 to 2 embryos according to the quality of the embryo. But above the age of 38 to 70 with the previous history, then you will go to more than almost 3 embryos. The number of embryos, putting sometimes more embryos than more than 2 or 3 embryos, it can in fact decrease the success rate of the infertility, because embryos, when you put them, they are in a fluid. And that fluid sometimes when you put more, then it's sort of rejection. It can come out. The implantation will be less. This is just a study how to recommendation regarding the number of embryos. And then we come to the luteal phase, which is most of the time you need a progesterone, and there are so many reasons why you need to have a luteal phase support, because of the super physiological estrogen, which can affect the respectivity of the endometrium, and that's why we need, and the luteal phase support usually done by the progesterone, either in an oral form. Nowadays, oral form is also very good and have a good success rate, or by injectables or vaginal. Factors affecting the rate of the success of the IVF, usually the age, ovarian reserve, number of previous cycles, duration of infertility. That's why I say duration of infertility, even sometimes with a good age, can affect the success rate of the infertility, the type of infertility, body weight, smoking, alcohol, the techniques used, the stimulation type, the lab is very important. When you advise your patient to go for IVF, please choose a center where they have a good lab. IVF success, usually 4 in 10 women will give birth after their first IVF. So it's around 30%, okay? So it's not 100%. But after by third cycle, almost 3 cycles, almost you will get 9 of the patient will get pregnant, inshallah. How safe is ICSI? Usually the ICSI is reassuring, but there are some problems regarding the autism, because usually ICSI is done for a male factor who is having already a problem. So if he has a problem, he may take that problem to his children, offspring. So that's why the problem with ICSI is more than IVF. There are so many studies comparing the natural conception with the IVF more than how is it with the ICSI or IVF. They say that the natural conceiving children are better in their gestational age, so that means that of course the natural conceiving, they will go higher, more advanced in their gestation rather than IVF. But with the FTE, frozen embryos, offspring of the frozen embryos are having better weight. Infertility treatment have severe maternal morbidity, and that's why IVF is considered and ICSI are considered as a high-risk pregnancy. They should not be treated with other population of naturally conceiving women. They have to have a separate, and they called high-risk pregnancy. What are the risks? It is, of course, you know, the risk of IVF during, they can end up very rare, interperitoneal bleeding, pelvic infection, torsion, ectopic, or chest, and all that. But the long-term complication, multiple pregnancy, prenatal outcome like low birth rate in the patient who are having IVF and ICSI, genetic abnormalities, congenital malformation, and ovarian cancer is not that much. So management of IVF, why they are? Because of the genetic. IVF, as I said, there is not much risk from the genetic point. ICSI, it's mainly because usually it's done because of the paternal reason, and if that father having an issue of a genetic problem, he may get it to his offspring. Fetal outcome, congenital abnormalities like congenital heart disease, so that's why you have to offer these patients to go for an early scan and check their baby's fetal heart to make sure that they don't have any abnormal heart. Risk of small for gestational age, IUGR, fetal growth need to be assessed very closely during the 3rd trimester. Placental findings, very important to put in mind. They are at risk of having abnormal placentation, insertion of the cord, vasa previa, accreta, all these things. So that's why it is important to follow up these patients, because they are at risk of having placental abnormalities, and that's why they need more assessment from 32 weeks onward. They are at risk of preterm, low birth weight, as I said before, and sometimes some of the patients, although it's not recommended to do cervical scan to check if they have a cervical incompetence, but you have to put that in mind, that these patients, they have a precious pregnancy. It will not harm you doing scan at around 14 to 16 weeks to make sure that they are normal. Hypertensive disorders are very well known that it's increased with an IVF and preeclampsia. Stillbirth is 2 to 3 higher fold than the normal pregnancy. So they are at risk of having stillbirth. They are at risk, that's why we recommend induction of labor between 39 to 40 weeks of gestation. In asymptomatic, uncomplicated single-term pregnancies, you can take them up to 39, but you have to put in mind that they are at risk of having stillbirth. So genetic counseling is very important when you do ICSI, especially if there is a male factor, and careful examination and do scanning at all stages, anomaly scan and then growth scan after that. The use of the IVF other than fertility treatment, yes, we do use them in the BGD, as I said. And then fertility preservation for the cancer patient. And of course, we are doing all this in the private. We don't have in the government. So we do use the fertility preservation for patients before going for chemotherapy, especially. We do aspirate their eggs and freeze them, or if they are married, we do embryo preservation, and then they will go for their chemotherapy. Sometimes if they are going for radiation, in fact, we do even surgeries where we take their ovaries from the pelvis and put them in the abdomen in order to avoid having their ovaries affected by the radiation. Unfortunately, because we don't have the availability of fertility preservation is not available in government, the minimum of GnRH and keeping them in the hypogonadism status during the chemotherapy, that's what we do, although it is not proven in many of the chemotherapies, apart from maybe some of for the breast cancer chemotherapy. And now we are going into the HLA typing for stem cell donation for the IVF. And in summary, improvement in vitro fertilization has improved so much after the 1970. IVF is a medical procedure that is efficient, safe, and readily accessible and relatively affordable. Nowadays, it's better than before. It's not like before when you can note I remember the cost before in early 2000 was around 5,000. Now it's sometimes you can do an IVF with 1,800, 6,000, 1,600 without XC or BGD. The practice, positive altitude, appropriate treatment, most of a fertile couple, alhamdulillah, they end up having a child. Studies indicate that the chance for pregnancy in consecutive IVF cycle remains similar up to the 4 cycles. After that, the chance of conceiving is decreased. Consider IVF pregnancy as a high-risk pregnancy, and you should not treat them like a normal patient. You have to have a separate category for these patients and include them in your high-risk pregnancy clinic. The use of IVF and XC technology in BGD and fertility preservation, it's well known now in the worldwide. Thank you very much.